tear the moment you walk in the door, whether you have pain or not. Okay. So if we ever MRI'd everyone at age 50, about 15% would have a tear, whether they're symptomatic or not. And again, at age 80, 50% would have a tear. Again, it doesn't mean you're symptomatic, it just means that you have it. And again, what you have to understand, look for is that tear causing your pain? Is it coming from your neck? Is it coming from your shoulder? What part of your shoulder is it coming from? So what are your symptoms for rotator cuff tears? Usually, first and foremost is pain. Overhead activities bother you the most. Lifting a dish out of a cabinet, or reaching for something on the top shelf, to get dressed, put on a coat, a shirt, putting your seatbelt on, reaching in the back of the car. All these things can have elicit pain. But the one thing that really tells me more towards shoulder pain than anything else is if you have pain at night. If you can't sleep on that side or it wakes you up at night, more likely than not, you're going to have some rotator cuff pathology. Now, all these other overhead activities kind of cross over with a lot of different other pathologies, but mostly shoulder pain at night, to me, is one of the bigger symptoms that you have. And people often tell me it's not my shoulder, it's my arm. It's here on my arm. It's not up on my shoulder, and that's what I refer to as subdeltoid achy pain, and that's because the nerve that supplies most of the muscles in your shoulder ends at the deltoid, and so it's referred pain from your shoulder, and you often feel it on the outside part of your shoulder or in the back of your shoulder. Other symptoms you can have are weakness, inability to rotate your arm, inability to lift your arm, decrease in motion. Often you can have an element of what's called adhesive capsulitis or frozen shoulder as another symptom of rotator cuff issues. What's not usually associated with rotator cuff tears is numbness and tingling in your hands. Unless you had a traumatic shoulder dislocation and tore your rotator cuff and your humeral head was sitting on the nerves of your arm, really you don't often have any numbness or tingling in your hands. And that's where the cervical spine overlaps with the shoulder a lot. So, what causes the tear? Two different main categories. One is a traumatic that you can't really help. If it's a fall, you have a sudden loss of motion and inability to raise your arm. It's something that happened, you slipped on the ice, you went to go grab something, all of a sudden you can't move your arm, rotator cuff tear. Patients over the age of 35 to 40, if they dislocate, will much more likely have a rotator cuff tear than other pathology that a younger athlete or person would have if they dislocate. The other is the atraumatic tears. Now this is intrinsic to the rotator cuff tendons themselves. They degenerate, they lose their blood supply. It's from repetitive overhead activities. And again, it's that impingement in between the humeral head and the acromion, which is not the cause, but does definitely contributes to the pain. So, what should you expect when you come to see me or any other orthopedic surgeon for your shoulder, or any other doctor for your shoulder? First and foremost is history. History and physical will tell me most likely or not what you have going on. Again, sleep pain or pain at night really is indicative of rotator cuff pathology. Physical exam, you want to examine the shoulders for any atrophy, meaning if the muscle is torn off the bone for such a long period of time and you're not using that muscle, it's actually going to atrophy, and you can see that in the back of somebody's shoulder. There's two different places where it's pretty evident. You want to go through range of motion and strength testing. And then even if you have an X-ray, even if you have an MRI, I usually get an X-ray as well. It tells me the status of the glenohumeral joint, whether you have arthritis or not, as well as the AC joint. And an MRI really is the kind of gold standard at this point for rotator cuff tears. So this part of the talk is more technical. It goes through kind of the different aspects of the exam of the shoulder, so that we can kind of pop through that and don't have to worry too much about it. But basically, you're putting your arm in different ranges of motion to isolate each specific muscle to see where we think you have a rotator cuff